So, restorative materials, it is the topic of today's lecture. Restorative materials for permanent and temporary fillings and linings. Lecture outlines such issues. So, first of all, it is classification of restorative materials for permanent, temporary fillings and linings, general requirements to restorative materials, composition and properties of restorative materials, adhesive systems, advantages and disadvantages of certain group of restorative materials, and of course indications for use of different groups of restorative material, in particular cements, amalgam and composite materials. Teeth are usually subjected to carious, non-carious lesions, and as a result of it, they need treatment. And actually, the treatment, the choice of treatment material should be selected according to a certain clinical case. And several factors should be taken into account when choosing the most appropriate restorative method and material for a certain clinical situation. And such limiting factors for choosing appropriate restorative material includes patient motivation and suitability, the number of remaining teeth and their relative position, the condition of the supporting tissues, the amount of remaining tooth structure, restorative materials available and their longevity as restoratives, occlusion and opposing teeth and restorations, aesthetic and other wishes of the patient, including cost factors. When any method or material is chosen, it must be used in the most appropriate clinical situation. Right now, ideal filling material was not invented, but still on this diagram you can see the most appropriate ideal requirements for restorative materials, and they should embrace such characteristics. First of all, it is physical properties. They should include low thermal conductivity and expansion, wear resistance to attrition, abrasion and chemical erosion. There must be also very good bonding ability to the tooth tissues. Biocompatibility. Of course, any material should be not toxic to tooth tissues and pulp tissue as well. Taking into account that fillings materials are in close contact with mucosa, tooth and pulp, so this characteristic, this quality is of great importance. Application. Any restorative material should be easy to manipulate, should be fast and quick to place in the carious cavity, should be easy to shape it. From the point of aesthetics, restorative material should directly correspond to the structure of the natural tooth, should have the same appearance, the same shade as the natural tooth. And X-ray contrast. Of course, it's a very beneficial property, and it allows for distinguishing restorations from the teeth and surrounding structures. It's very helpful in clinical maintenance. Nowadays, we have several classifications of restorative materials, and they are as follows. First of all, according to the group of teeth, for anterior and for posterior group of teeth. According to the material from what the certain restorative materials are produced, they are divided into metals and non-metals. Metals, it is amalgam, alloys, pure metals, and non-metals, it is cements, resin, composite materials. According to the purpose, restorative materials are divided for permanent restoration, temporary fillings, linings, and fillings for the root canal. According to the purpose, in particular, we must classify in this way. Permanent, for permanent restorations, we have glasionomer, composite, amalgam, compomer. It is combination of the composite and glasionomer cements. Temporary dressings, we have such cements. Zinc sulfate, it is dentin powder or dentin paste. Zinc eugenol cements, polycarboxylate cements, zinc phosphate cements, and glasionomer cements. Materials for linings, they are as follows. For isolative lining or base lining, we have zinc phosphate cement, glasionomer cement, polycarboxylate cement. For therapeutic or treatment lining, we have such materials. Those that are based on calcium hydroxide, zinc oxide eugenol cements, and combined therapeutic pastes. Not satin, they are prepared extempore. And now we move to the materials for permanent restorations. So we have glasionomer cements. This material firstly were introduced in dentistry in 1970s, and from that time they have many applications, including restorations, lining and bases. They can be used as well as endodontic sealers and fissure sealants. Glasionomers have two significant advantages. They adhere chemically to enamel and dentine, and they release fluoride. And that is very beneficial when it goes about numerous caries cavities. On this diagram, you see the timeline of the development of glasionomer cements, how everything starts and how it is now. So you see that the first material were introduced in 1970s by Wilson and Kent, and actually it was a traditional glasionomer cements. They were mixed on water, and they have some disadvantages. They were not so strong enough. For that reason, development undergoes, and some addings of silver particles were given to the material, and now they were reinforced. They possess better strengths, they were better wear resistant, but still they were not good enough, they were not aesthetic, and development goes ahead. And later, company 3M, SP, introduced resin into glasionomer cements, and actually the introduction of resin makes them more easy to manipulate, more aesthetic, and at the same time they start to be stronger. They could even be used as a second-class restorations from that time. And pay attention that development undergoes, and they were not only the chemically activated materials at the conventional one, but they start to be light activated materials, but for the first they were dual activated materials. Both chemical and light curing activation were used. And this is very beneficial because conventional materials were subjected to moisture contamination as they are not hard enough. But light curing gives them ability to hard faster, and thus the material were not subjected to the moisture and were not destroyed by the environment of the oral cavity as a result. And you see that in the 2000, nanoparticles were given to the composition of restorative material, and these nanoparticles are very good because if nanoparticles is given to the material, the properties are improved, and such properties as wear resistance, toughness, fracture resistance. And still the development of glasionomer cements continues. And we are waiting for new formulations of them. For now, we have such classification of glasionomer cements. It was introduced in 1991 by Philips. According to this, we have first type, second type. Basically, this second type is used in restorative dentistry. Cements for restorations, they have a good strength and lower solubility in comparison with other glasionomer cements. They are divided for subtype A, subtype B. Subtype A for aesthetic restorations and used for restoration of class 3rd and 5 cavities, and also for treatment of uncarious lesions. Subtype B, they are reinforced. It means that they have increased strength to the stress in the load-bearing restorations. Such materials are Fuji 9, company JC, This material is used for both for permanent and primary teeth, can be used as postponed restorations of permanent teeth as a second-class cavities by Black and the sandwich technique. Third type of glasionomar cements, it is cements for linings. Such representatives you see baseline, aqua, ionobond. Fourth type, it is dual cure cement. They possess both chemical activation and light curing activation. And another group, separate group of glasionomar cements, it is materials for root canal obturation. They are used in combination with gutta-percha points. Composition of glasionomar cements. It has in its composition powder. Powder consists basically from fluoroaluminosilicate glass, water solution of polycarboxylic acid. It is a separate. It could be separate in a separate bottle or can be added as a dried. As a dried acid into the powder formulation, and such component as tartaric acid is given, radio opacifiers and pigments. So it is the composition of glasionomar cements. Formulations. Nowadays, it is available in two possible formulations. It is hydrous type and anhydrous type. So hydrous type means that in the box of restorative material we can find a bottle with powder and bottle with liquid. So basically powder, it is fluoroaluminosilicate glass, and liquid, it is organic acid. It is copolymer of acrylic acid with itaconic or maleic acid. It is 47.5%. Anhydrous type, basically it is conventional glasionomars cements. It means that in the box we can find only bottle with powder and liquid. It is distillated water that is used for mixing. Acid, copolymer of acid, it is dried acid, is added to the powder in this type of glasionomar cements. So anhydrous type basically refers to conventional. Properties of glasionomar cements. They are biocompatible material. They don't provide any toxic influence to the pulp tissue. They have a very good bond to tooth substance due to ion exchange mechanism of retention. They provide fluoride release, basically constant fluoride release, and even they can be recharged. They have sufficient mechanical strength and elasticity. They have appropriate aesthetic features because they are produced in shades. They are radio-opaque, and that is very attractive. They provide no irritation action to the pulp because they are biocompatible, and they need moisture for setting. They are hydrophilic. Actually, bonding to tooth surface, how it is explained. Glasionomar cement can bond to the calcium of hydroxyapatite of dentine and enamel. This is very positive quality because when restoration is lost, there is usually a thin layer of glasionomar cement left on the dentine, and the pulp dentine complex will remain protected therefore. And you see on this electronic microscopic picture that actually there is a combination, like material combined with the tooth structure. It penetrates into dentine and creating tags. Somehow we can call it tags. Fluoride release, another advantageous property of glasionomar cements. Fluoride release, it is sustained process and occurs over a long period of time. It is important to realize that this fluoride ion release is a result of the setting reaction and the ion exchange process in the cement. Moreover, when glass ionomer, the very positive effect of glass ionomer cement that it can be recharged from routine applying of fluoride to tissues, or even from the toothpaste, it can absorb fluoride and again introduce it into the dentine tissues, and thus preventing secondary caries occurrence. Mechanism of action. So a mechanism of action, it is a mechanism of retention, it is ion exchange mechanism. It's necessary to remember, I am stressing on this point your attention. So here you have the theoretical diagram that gives you understanding of how ions penetrate into dentine, incorporating with the dentine, replacing one another, and thus creating the specialized tags for keeping the material on its place. So each phosphate ion takes with it a calcium ion to maintain electrolytic balance, thus creating an ion-enriched layer. Setting reaction, actually it has a few stages, starts everything from the dissolution. On this stage, the polyalkanoic acid in the presence of moisture releases protons which attack the surface of the glass, causing the release of fluoride. Gelation stage. Free divalent calcium ions from ionic bonds with the negatively charged carboxyl ions on the polyacid chains. During this stage, the material firms to the touch. This is critical. On the hardening stage, it usually starts after 3-6 minutes of manipulation. And during this phase, trivalent aluminium ions form more effective cross-links between adjacent chains. And maturation stage, it lasts during 24 hours and can continue its, so the filling can continue its maturation even during 1 year. So may take several days to complete, and only then does the material reach its final strength. That is what is done on this maturation stage of the setting reaction. Manipulation of glass ionomers. The first, it is conditioning stage. In the set of material, together with powder and liquid, some manufacturers add conditioner. Conditioner, it is 10% polyacrylic acid. The main task of this conditioner to clean surface of dentine from smear layer. It not removes it actually, but modifies. And you see the microscopic representation that dentine tubules is not open as it is etched by phosphoric acid for resin composites, but just a little bit opened, just smear layer is modified. And some amount of bacteria is removed at the same time. Manipulation. Manufacturers recommend so first of all, necessary to follow instructions by manufacturer. Generally, manufacturers recommend to take in equal proportions powder, liquid, 1 spoon of powder, 1 drop of liquid. At first, it is necessary to incorporate half of the material with the liquid, and then the rest amount of the powder should be mixed together. Restorative material, so ready-to-use material, can be placed in the caries cavity by 1 or 2 portions, appropriately condensed and shaped. After it was condensed and shaped, manufacturer recommends to coat the outer layer of glacionomar cement by a specialized liquid, varnish. The task of this varnish to protect material from wearing away during mastication at the initial setting time. And as you know, that's setting time for glacionomar cements 24 hours. It is for conventional glacionomar cements. Reinforced cements basically are polymerized during the first 10 minutes. The final stage of handling glacionomar cements is polishing. We have two types, autocure, conventional glacionomers, and reinforced. And actually the polishing techniques for these two groups of materials are different. For conventional glacionomar cements, polishing can start in 24 hours. So that's why the patient should come for a second time for final finishing and polishing. Because if polishing is done after placement of the material, it will be totally destroyed. In the case of restorative reinforced glacionomar cements, polishing can start after 6 minutes of being placed into the carious cavity. For this procedure of polishing, I used specialized finishing polishing burrs together with paper discs, polishing rubber cusps and points that are fixed in a conventional handpiece, counter-angled handpiece. Glacionomar cements possess such property as post-operative sensitivity. This post-operative sensitivity were high for anhydrous type because dried acid were introduced into the powder, and and for mixing is used water, distillated water, and you know that glacionomer need moisture for polymerization, and in a case of this anhydrous type, glacionomer cement can take water from pulp to polymerize as well if some handling notes were not appropriately maintained. So the patient could feel pain after placement of glacionomer, especially anhydrous type. This could happen due to such reasons. First of all, desiccation of the tooth. The glacionomers require water for their setting and may absorb water from the dentinal tubules during this process. Due to initial low pH of the material, this low pH may irritate the pulp at the initial stages, but later, on the later stages, pH increases due to moisture contamination that leads to poor sealing of the tooth and improper margins, hence leakage to bacteria and their byproducts available, and due to low viscosity of the mix, causing fluid to be forced down the dentinal tubules during setting reaction. And actually, these are the main possible reasons why post-operative sensitivity can develop in anhydrous type of glacionomer cements. Indication. So, it is a universal material, glacionomer cement, especially reinforced ones, but conventional as well can be used in different cases. First of all, this material is material of choice in a case of poor moisture control in posterior distal cavities. We should keep in mind that this material even need moisture to polymerization, so a good control of moisture is not of critical importance, but still working fields should not be wet a lot, because it can lead to some voids and restoration would be compromised. Second clinical indication, for rapid stabilization of a dentition where there are multiple cavities in a patient with a high caries risk due to fluoride release. They can be used as an atraumatic restorative treatment because they are easy to manipulate and they don't need any special cavity preparation except the caries removal. They can be used in the first and third class restorations, root caries, especially in adult patients, 5 class by black cervical lesions. But these indications can be for conventional traditional glass ionomer cements. First, third, root caries, and 5 class by black. Conventional glass ionomers are used in these cases, but still reinforced can be used as well. No one prohibits you to do so. But for second class cavities with load-bearing occlusal cusps, were used reinforced glass ionomer cements, such as Food G9, GC company, for example. And don't forget about linings. Glass ionomers can be used as a lining, especially in a sandwich technique, to replace the dentine. The main task in the sandwich technique of glass ionomer to replace dentine, because one of the properties of glass ionomer cements that they correspond to the thickness of dentine. They are similar, as strong as dentine, and during occlusal pressing they won't do harm to the pulp tissue, and occlusal press will be distributed appropriately on the tooth. This diagram gives you information of sandwich technique. It can be open and closed, as you see. Open means that we have glass ionomer cement in the second class as a base for replacing dentine, and above it to replace enamel resin composite can be used, because resin composite is more aesthetic in comparison to glass ionomer cement. In a closed sandwich technique, glass ionomer is placed to the pulpal wall, and above it we have the covering of light curing composite. So glass ionomer cement is not subjected to oral environment. It is covered totally by resin composite. Steps of sandwich technique, we have such. First of all, to isolate the tooth from saliva. Second, provide conditioning of the prepared caries cavity with 10% of polyacrylic acid for about 10 seconds, then wash away. Thoroughly dry, carefully, not to over dry. And third stage, glass ionomer placement in a caries cavity by 1 or 2 portions. After that, shaping and condensing of glass ionomer, condensing and shaping of glass ionomer cements. And after that, applying etching gel, washing it, and applying a bond system, or can be applied self-adhesive bond system without washing stage. It depends. Glass ionomer can go both with total etch or self-etch technique of adhesive systems. Then light curing of adhesive system. If it was total etch or self-etch, it doesn't matter. And after that, the placement of the composite material and light cure it appropriately 15-20 seconds. And then final finishing and polishing of the restoration with finishing, polishing, discs, points, paper points. And we move to advantages and disadvantages of glass ionomer cements. First of all, advantages. They are great, and here you have. First of all, due to ion exchange mechanism of retention, there is no necessity for applying any bonding agents, and moreover, this material has not so good adhesive properties as light curing composite, but still retention is good due to this ion exchange mechanism of retention. They don't need any special cavity preparation except caries removal. They are not subject to shrinkage and micro leakage. That's why appearance of secondary caries and recurrent caries is limited. Glass ionomers contain and release fluoride. Moreover, they can be recharged by using fluoride-containing toothpaste or fluoride-containing varnishes. They are not afraid of moisture contamination to some extent, of course. Very beneficial property that bacteria can't adhere and grow on glass ionomer surface due to fluoride release. And once again, secondary caries is not so typical to occur in the tooth that have the restorations with glass ionomer cements. The coefficient of thermal expansion similar to dentine, and this makes them very attractive when it goes about occlusal forces. Disadvantages of glass ionomer cements. They are lack of adequate strength and toughness. Yes, it's true. Failing rates somehow is great, but still, even if restoration is lost, a thin layer of glass ionomer is still left, and thus protecting the tooth from further caries attack. They are sensitive to the presence of moisture during hardening, should not be over dried in the stage of setting, because over drying leads to post-operative sensitivity. Glass ionomer cements need moisture for polymerization. If such is not present, they will take it from pulp and causing irritation of it. They have a long setting time for conventional glass ionomer cements, approximately 24 hours. There is a risk of irritated action on the pulp in deep cavities due to desiccation. Actually, this is the reason. That's why they can't be placed in the close proximity to the pulp tissue. No, basically anhydrous type conventional glass ionomers. Fillings do not wear as well as composite resin fillings. Glass ionomers are about as expensive as composite resins, but still they are generally considered good materials to use for root caries and for sealants, and they are very attractive for pediatric dentistry as well. Examples, propose examples to your attention, and I just collected few, the most widespread and the most famous brand names. So we have JC, America, Fuji 9. So this material is reinforced, available in powder liquid formulation. Then we have Keramfil. This one is available in shades as well as Fuji. Few shades are possible, so to some extent glass ionomer cements are aesthetic restorative materials. So Keramfil, such material, recommended for class 2, 5 and non-carious lesions such as erosion. Ionobond, Vocco, available as well in powder liquid formulation. This material is manufacturer recommend to use it even in a core build-ups because it's strong enough. It is self-curing, it means chemical activated. Don't require any preparatory conditioning of the dental surface. So this manufacturer recommends not to use conditioner. SDI company material Riva, indications non-stress bearing class 1 and 2 restorations, temporary teeth restoration, adult treatment of adult patients, intermediate restorative and base material for class 1 and class 2. In a sandwich technique as well, it can be used for record build-ups, temporary fillings. It can be used as ART technique. PMSP company provides glasionomer cement Ketak molar. It's packable and condensable material used in ART technique for deciduous restorations as a liner. It is not aesthetic. It is available only in one shade, white actually, in comparison to Fuji. Indications, class 1, core build-ups, primary teeth fillings, base material for composite fillings, class 5 restorations. And here I give you one type, one example of anhydrous type of glasionomer cements. Actually, they are of rare use in dentistry, but still Dentsply still produce this one, Hemfil. Actually, it was the first material to appear on the dental market, Hemfil, this material. The pioneer of glasionomer cements. It is fast-setting glass ionomer restorative material that consists of a blend of aluminosilicate glass and polyacrylic acid in the powder. Powder is mixed with a distillated water. They write that it is strong and aesthetic. So we have finished with glass ionomer cements, those that is considered to be conventional and reinforced, and we move to resin modified glass ionomers. So it is a further development in glass ionomer cements were introduced in 80s to the dentistry market. So they have the name Compomer. Excuse me, not Compomer, say Hermegis, resin modified glass ionomer cements. They have monomer component and polyalkanoic acid and fluoroaluminosilicate glass of conventional glass ionomers. They are more attractive from the point of aesthetics and from the point of being wear resistant, more wear resistant in comparison to conventional and reinforced even, and low fracture occurrence. The main company, the first company who introduced this material were 3M Esper and such material with Remer. It possesses triple curing technology. Actually, it is patented triple curing technology for this company. Light curing chemical curing and additive glass ionomer satin reaction. Light curing, chemical curing, and additive glass ionomer satin reaction. That is the patented triple curing technology for Hermegis. Especially this material with Remer, you see here, I put this set of box. It has bottles with 6 shades, so it's to some extent aesthetic, and 2 special shades, 6 standard and 2 special shades. That's why it is considered to be aesthetic one. It has low abrasion, high rate of fluoride release. Such indications: core build-up, filling undercuts, class 1 and 2nd restorations in primary teeth, class 3rd and 4th restorations in cavity lining. We move far, and now we are talking about Compomer. It is polyacid modified resin composites. Right now, this is old-fashioned name, and modern dentistry use the name Compomer. And actually, it's acronym composite and glass ionomer. From composite, it takes durability and aesthetics, and from glass ionomer, it takes fluoride releasing ability, making them caries resistant material. The main examples are here. It is material for restoration, condensable. It's a Compo Glass F, and flowable material, direct flow. It can be used as a lining, because compomers basically are used as base liners in dentistry, but still can be used as a restorative material in a pediatric dentistry because they release fluoride. They are appropriate for prevention high caries incidence, second caries, recurrent caries. So their indications, it's linings, base linings, sandwich, in the sandwich techniques they can be used, and pediatric dentistry is a favorite usage there. And now we finish with glass ionomer cements and their modifications and move to resin composites. So resin composites are increasingly used nowadays materials because they are very aesthetic and strong enough to stand occlusal forces. Development of resin composites. Everything starts in the 60s. The first material were introduced at this period. Later were, so if the first it was chemical activated materials. After that light curing were developed. Further development, microfield composites with the small particles of resins, of filler, of resin filler. These materials were not strong enough, but they were aesthetic. I didn't say you that the initial, it was macrofield, actually in 1960s, it was the first material to appear. It was macrofield composite. The resin particle, the filler particle were big, they were strong, but they were not aesthetic. The polishing were very bad, and for this reason, chemistry evolved microfield composite with the smaller particles of filler, and they were very polishable and aesthetic, but they have disadvantage, they were not strong enough. Development continues, and dental market provides right now hybrid composites. They possess both macro particles and micro particles, big and small particles of filler, and thus they possess both aesthetic and they are enough strong for occlusal forces. In 90s, 2000s, development undergoes, and we have materials with nanoparticles, and these nanoparticles makes material very attractive for aesthetic and for polishing, so the physical properties more improved. And in 2009 were introduced special material, bulk film composite material by the company Care. Actually, it was the first company who introduced this material on the market. I want to say that the previous packable materials, that what I was talking before, it was packable or condensable. They were used, the main idea of using is incremental placement, but it is time consuming, and due to this time consuming procedure were developed bulk fill composites that they can be placed by the increment of 5 millimeter and appropriately cured. So it's saving time for the dentist and make its work effective. And in detail, I will talk about it during this lecture as well. This is just to show you how everything starts. And actually, the development goes ahead, and we are always waiting for something new. Chemistry, dental chemistry don't stand on its place and always moving ahead. So composition, it's the essential first step about introducing this material. Talking about its composition, so resin matrix we have, basically it is fluid monomer bisgma, or can be tegaderma, depends, but bisgma is the common. Then we have filler particles of silica-based glass. Then we have activator for the setting reaction, that is normally camphorhinone. I will stress your attention at this. And silan, it is agent that allows the resin and filler particles to bond together. And of course pigments to make them aesthetic. Classification of resin composites as well, available few possible classifications, and the first one according to the curing modes. It can be chemically activated, light activated, and dual cure. Chemically activated or self-cure materials are available in such formulations: powder liquid system, paste system, paste liquid materials. Light activated materials are available in syringes and such as encapsulated materials. Examples of self-cure composite materials: powder liquid. It was to some extent the first material that were introduced in dentistry, one of the first. I cannot say the first, but one of the first. And this formulation, powder liquid, is basically out of use today, but still company Spofa Dental, such material as Avicrol, produce it even till now. It has such indications: class 3rd, 4th, and 5. Filling of hard tissues, defects of non-caries etiology. Of course, we should keep in mind that this material is not as aesthetic as modern nano-hybrid restorative materials. Self-cure composites, formulations, paste. The most famous representative of this group is a company Kulzer. Material Charisma, base catalyst we have in 2 boxes. We have adhesive system of the 4th generation and etching gel in the set of the material, and such material Master Dent, Dentonics, it's company Dentonics. Similar set of material: paste, base catalyst, adhesive system, but etching gel is in liquid. Here it is in the gel, in syringe, but in this material etching liquid is in bottle, so it's liquid. Similar indications as for Charisma. Light curing composite representatives. We have, once again, I must say that I just collect here the most widespread and famous companies. So JC company, material Gradia Direct, it is micro-hybrid composite, available in syringes, available in different shades. Even this company provide anterior and posterior shades. So it is very useful and very good for doing restoration. Very comfortable. Such a company as 3M SP, material Filtec, as well in syringes, as well they have adhesive system in its composition, in its set. Company Care, material Herculite, micro-hybrid composite, provided in enamel and dentine shades. And Unidoses, usually the same material of the same company can be available in unidoses. And for this, we use such special capsule dispenser gun to introduce this unidose material into the carious cavity. Classification of composite materials based on a filler size. So we have macrofill, microfill, hybrid, nano-hybrid, and different combinations of them. So macrofill possess big particles, have in its composition big particles of filler. And you can see here this diameter of particles. Due to these big particles of filler, they are strong but not aesthetic, not good at polishing. Later were introduced microfilled materials. They possess smaller particles of filler. They are not so prone. They are not so strong, but still they are very aesthetic due to the polishing qualities. Hybrid possess combination of macro and micro filled components, thus it's a universal use material. And nanoparticles were introduced, and now almost all materials is nano hybrid composites. That means that they have better aesthetic, better retention. They are not so prone to polymerization shrinkage, but still polymerization shrinkage is available in resin composites. Another classification of resin composites based on clinical application. So light cure composite can be universal, used for one force classes. Aesthetic, in that cases where aesthetic is not critical, this is universal. Condensable, they are used for 1 and 2nd class cavities. It means that they are strong enough for 1 and 2nd class. They can stand occlusal forces. They can be used when they're necessary to restore cusp even. And manipulation with this material is similar to condensing the amalgam. So even they are called somehow white amalgams, but it is just like for joke. We can't say that it is, we can't maintain light curing composite as amalgam. Still, condensing is necessary, but the main idea is gently distributing the material on the carious cavity and a little bit condensing, especially if it goes about condensable, because the material can be hard enough to distribute only. Flowable. Flowable materials, they are attractive in cervical restorations, or they are used, basically they are used as a cavity liners, and we have such idea as a soft start, and actually flowable material is used in this case at the initial, the first layer in the carious cavity, and only after that would be placed light curing composite material. It doesn't matter if condensable, universal, or bulk fill, but the initial layer is a flowable light curing material. It will distribute the occlusal stress appropriately and thus prevent pain to the patient. And bulk fill composites, they are used in a deep cavities, possibly in a deep cavities, for quick and fast restoration of them. Manufacturer actually claims that they don't have a very big polymerization shrinkage. Actually, the manufacturers state that polymerization shrinkage of bulk fill composites is similar to that of universal or condensable light curing composite materials, despite that bulk fill composites are used in a thicker layers, 4-5 millimeters, and light curing condensable or universal, they are used in the incremental layer not more than 2 millimeters, so a very thin layer to a little bit reduce polymerization shrinkage. So on this slide, I have collected light curing composite material flowable and bulk fill, the main representatives. So you have Takayama Estelite, Flow Quick, Admira, Flow company Voco. By the way, company Voco, it is the first company who introduced nanoparticles in dentistry, and they are using it very effective, and almost all materials, nano hybrid, are produced by the company Voco. But still a lot of other manufacturers use this technology of nanoparticles in their productions of materials. Bulk fill materials such as Opus and SureFill as their company, SureFill Flow Plus, bulk fill flowable composite. Company Dentsply. By the way, this company Dentsply were the first one to introduce the bulk fill material in the dental market. Technique of applying. So incremental layering technique is accepted as a gold standard for the placement of resin-based composite restorations. When restoring cavities, conventional light cured composites should be placed in increments of thickness generally not exceeding 2 millimeters, so very thin layers, layer by layer, trying to catch only few walls, not putting the material on opposite walls. It is recommended to put material on the wall and on the floor of the cavity. And here you have on this picture the first, it is flowable composite, and second, 3, 5, 4, and 5, it is layers of resin light curing composite material. Thickness of layer is not more than 2 millimeters. However, the latest development in composite technology are materials intended for posterior bulk fill placement, bulk fill resin-based composites. This material can be applied in increments up to 4 millimeters thickness, and such company Care recommend his material sonic fill system. They advertise it that even 5 millimeters would be appropriately polymerized and with a shrinkage not more than for conventional light curing composites. They claim actually that shrinkage won't be bigger, would be the same. And why I am always talking about polymerization shrinkage, because it is adverse property of resin composites. And usually this polymerization shrinkage is in order of 2-3%. For self-cure shrink, by the way, self-cure resin composites shrink toward center of restoration, and for opposite, light curing composite shrink toward the light source. It's of critical importance. That's why I'm stressing in this lecture on this idea, polymerization shrinkage. Together with this with this property, resin composites have few more, and they are as follows: biocompatibility, easy to manipulate, appropriate control of working time when it goes about light curing composite materials, and of course limited working time when it goes about chemical activated materials. They are strong enough they are wear resistant, but flowable are not wear resistant. That's why I wrote here wear. So flowable resin composites are subjected to wear, but other resin composites are strong enough to stand different occlusal forces, and they are they are X contrast. They have a good thermal conductivity and water absorption. So these are the properties of resin composites, and one of the most important property is polymerization shrinkage, and actually that's why I'm talking about it constantly. How to reduce polymerization shrinkage in resin composites? First of all, it can be done by incremental placement of light curing material, layer by layer, trying to attach material only to two walls, wall and floor, and such incremental layers should be done. Every layer is polymerized, and as the base is flowable composite is recommended to put. Second possible way how to reduce polymerization shrinkage. It can't be removed, it only can be reduced. So by directing the light source from the opposing side of carious cavity, taking into consideration that shrinkage occurs toward the light source, at the same time material adhere to the wall of carious cavity, proximal cavity, and the stress induced by polymerization shrinkage is highest in cavities with more bonded than unbonded surfaces. It means that occlusal surfaces class 1 is more susceptible to polymerization stress. Clinical use of resin composites. They are indicated in different cases. It is considered to be universal use material, especially in situations where aesthetic is of great importance. We should pay attention to that situations in which resin composites are not suitable, and they are as follow. Deep subgingival preparations, because it's hard to provide good moisture control. Lack of peripheral enamel. It means that this material can't stand occlusal forces because they are strong, and actually if opposing tooth will press on such restorative material, there could be a fracture of the tooth or even the fracture of the root. That's why they can't be used as the core build-ups. They have the poor moisture control in the situations where poor moisture control. No, of course, because this material demands very dry environment for appropriate setting, and they are prohibited in the load-bearing cusps. Yes, I told it before. They are not used as a core build-ups because they are strong and can cause fracture of the tooth crown or worse, root of the tooth. Advantages and disadvantages of these materials. So resin composites are aesthetic, they are easy to manipulate, they are biocompatible, they are X-ray contrast, they are strong enough, but not for core build-ups. Disadvantages: polymerization shrinkage, marginal gaps as a result of it. As a result of marginal gaps, there is a micro leakage in which microorganisms can flow, and as a result secondary caries development. Low strengths, low fracture toughness, and they are not so wear resistant as ideal restorative material should be. But still they are good material for restoration, and basically they are famous in restorative procedures due to a lot of positive qualities they are possessing. Talking about resin composites, we can't about the adhesive systems, because without adhesive system, resin composites can't work. because they don't have any bonding to tooth tissues. And actually, the resin composites rely on adhesive systems for formation of appropriate. And nowadays we have two possible etching systems. It is total etch and self-etch systems. The development of etching adhesive systems were simultaneous with resin composites. And everything starts with Buonocor in 1955 when he introduced the first generation of adhesive system. The first three generations right now is out of use. It's historical aspect. They were no acid based. But later were introduced total etch method. It is the fourth generation. It provides micromechanical retention to the dentine and enamel. Micromechanical, I should stress your attention at this term, micromechanical. Interlocking were possessed in this fourth generation of adhesive systems. They were later developments were fifth generation in the 90s. This happened. This was in the middle 90s. In comparison to the fourth generation, fifth was faster to manipulate, easy and quick, but still development continues and evolve sixth generation of self-etching method. So total etch method, fourth and fifth generation self-etching method. It's 6th, 7th, 8th generation of adhesive systems that are available nowadays. 6th, 7th, 8th, that's the last one that available nowadays. In this self-etching methods, they were introduced in 2000. So washing stage is omitted, and again, easy, fast and quick work of dentists are maintained. This diagram gives you a very good, clear understanding of the classification of adhesive systems in this generation. So we have total etch system, self-etch system. In a total etch system, what I want to say, all of them are right now on the market. So you can find them and use with a certain restorative resin composite material. So in the fourth generation, we have etching gel, we have primer and bond in two separate bottles, and this is called 3 steps. We have fifth generation, we have etching gel, we have self-priming resin. It means that primer and bond in one bottle. So we have 2 steps. It's faster than the fourth one. And now we are in a self-etching system. We have here 6th generation. Etching gel is not available. We have self-etching primer, so etching liquid and primer is in one bottle, and after that is applied bond resin. So washing stage is omitted. 7th generation, we have bottle A and bottle B mixed together, and then apply the material, and then apply the adhesive system to the caries cavity. So we have the single step. We just apply one time, but should mix liquid from bottle A and bottle B. This self-etching system possibly have some benefits because due to this omitted of washing stage and possible contamination of oral liquid as a result of it. But quality of enamel etching can be somehow questioned due to the absence of this etching gel separate as a separate step. But still, every dentist can choose for himself that what is most convenient for him. Eighth generation of bonding agents were introduced in 2010 by the company Voco. Actually, nanoparticles they gave into this bonding agent. And nanoparticles increases the penetration of resin monomers and the hybrid layer thickness, which in turn improves the mechanical properties of the bonded systems. Examples of 8th generation: Voco Futura Bond M, easy, fast application, one coat, one cure technique. No, it's obvious, it's very easy and quick. Universal for all light curing restoratives. And Futura M Bond tolerates residual moisture. That's why the surface should not be over dried. It's we have such an idea as a wet bonding, and actually it tolerates in this Futura Bond M Plus by company Voco. Another manufacturer that introduced the 8th generation of adhesive system, it is company JC Bond G Premio. How to use it: apply for 10 seconds and then dry thoroughly for 5 seconds under the maximum air and light cure for 10 seconds. Total etch technique versus self-etch technique. So here I put the microscopic diagrams from electron microscopic that you can see what is the difference in etching. So of course, in the total etch technique, smear layer is removed and open dentine tubules are available, and thus resin composite adhesive system can easily flow into them, creating specialized tags, so-called hybrid layer. But in this case of total etch method, there is a possible over dry of dentine due to drying stage, and the over drying of dentine possibly could lead to collapse of collagenous network, and as a result, resin composite adhesive system can't flow into open dentine tubules and can't create tags. That's why restorative procedures are compromised and are not good. And one more possible disadvantage, that dentine tubules are exposed to oral environment during washing stage. Possible risk of contamination by oral fluid. But the very good positive quality is etching. Etching is really good in comparison to self-etching methods, if you compare even the electronic microscope pictures. Here you see mild self-etch adhesive. It is actually that what we are calling single step. Actually, it is the 8th generation, and strong. It's is a single. Excuse me, I was wrong. So 2 steps. It's a mild self-etched adhesive, that what of 6th generation, and single step, it's a strong self-etched adhesive, that what is 7th and 8th generation. So in the case of 6th generation plane of adhesive system of 6th generation, removal of smear layer is not so good as in comparison to the 4th or 5th generation. But there is advantage. There is no stage in the proceedings when there are open dentinal tubules exposed to the oral environment, and that there is no contamination by oral liquid. Moreover, there is no danger of over drying, thus collagenous network couldn't be collapsed. The only one disadvantage, as I said, its quality of etching is not as effective as with phosphoric acid. That's why some manufacturers recommend to apply additional etchant to enamel only. But this is actually not good, and it's a defeat, not the success of this material. Acid etching technique. For chemical curing composites, acid etching with phosphoric acid removes smear layer and creates pores with the enamel into which adhesive flows to create tags. And actually this micromechanical retention is very reliable unless there has been contamination of the etched surface by saliva or blood. For light curing composites, acid gel is applied both to enamel and dentine, causing demineralization of dentine and removal of hydroxyapatites from the dentinal tubules, and as a consequence, mechanical interlocking is achieved by adhesive resins flowing into open dentinal tubules to form resin tags, so-called hybrid layer. When we are talking about resin composites, you should keep in mind these terms: smear layer, hybrid layer, and oxygen inhibited layer. So a smear layer, it is layer that creates after cutting the dentine. It is layer that has microorganisms, debris after cutting, and it is usually removed by phosphoric acid from etching gel. Hybrid layer, it is layer that is formed when three-dimensional collagenous network is infiltrated by primer and resin to form a resin tags. And oxygen inhibited layer, it is outer superficial soft sticky layer that is not polymerized. That's why if it is not cut away in a stage of final finishing of polishing, the restoration will absorb stains and would be not attractive. So it is recommended to overbuild restorations, somewhat overbuild, and later on the stages of finishing and polishing to cut the excess of material to remove this oxygen inhibited layer and give shiny appearance to the restoration and strong enough. So this diagram shows you how the resin adhesive system flow into dentine tubules and creates tags. Here you have the smear layer. Here you have smear layer dissolved using acid. Here you have the empty tubule, and now the resin flow into the dentine tubule, closing it. So this is the formation of hybrid layer. Stages of acid etching. We have such stages. First of all, etching time. This should be sufficient to cause effective etching, as evidenced by a white, chalky appearance on the treated section of enamel after washing and drying. The etching time normally is used 10-60 seconds. In average, 15 seconds is recommended. Etching gel is applied both to enamel and dentine. If it is etching, for resin light curing composite. Washing stage. Washing stage is of critical importance, necessary to wash twice longer than etching. Washing should not be with a high stream of water, but gentle applying of water to the carious cavity just to remove all parts of the etching gel, and should not be strong enough to introduce it into the open dentine tubules. Just a light stream of water to remove the etching gel from the surface of the carious cavity. Twice longer than etching. It's critical to remember. And drying stage. Drying stage in the stage of, so the main what you should remember when it goes about drying stage, not to over dry. This is important because if dentine is over dried, collagenous network collapse and hybrid layer cannot occur. And thus, restoration is compromised. It's not qualified, it's not good. And keep in mind that resin adhesive systems, they are hydrophilic philic to some extent, but still we have such idea as a wet bonding. So some amount of moistened dentine. Dentine can be a little bit moistened to provide good adhesion to resin system to tooth tissues. That's why this concept of wet bonding you should keep in your mind as well. Wet bonding, not to over dry, the main idea. To check the quality of etching, it's very simple. So appropriately etched enamel is porous, white, chalky appearance. Stages that represents acid etching, bonding, and placement of light curing composite restorative material. So everything starts from applying etching gel for 15 seconds. Both to enamel and dentine if it is adhesive system for light curing composite. If it is adhesive system for chemical activated composite, etching gel is applied only to enamel because adhesive systems are only for enamel in the chemically activated resins. But in a light curing, it is both enamel and dentine resin adhesive systems. So applying etching gel, then washing it twice longer than etching time, with a light stream of water, but with appropriate amount of water to wash to wash gel from the caries cavity. Next step is drying. Drying stages of critical importance. Enamel and dentine should not be over dried, as over drying leads to collapse, and as a result there won't be a formation of a hybrid layer. Next step is applying of adhesive system. One drop is applied on the micro brush and then gently distributed both enamel, dentine, walls and floor of the caries cavity. Then give a few seconds for evaporize, or you can use the light stream of air to distribute a little bit the adhesive system over the caries cavity. But be careful that in the 3-in-1 syringe should not be any drops of water. If such happens, restoration is compromised. After distributing adhesive system by light stream of air, or just given a few seconds to vaporize, it should be the next essential stage is light curing. Light curing of adhesive system 10-15 seconds, and then applying light curing composite material. At first flowable composite material, because we keep in mind such idea as a soft start. And then every layer of material should be polymerized by light curing lamp in ranges from 15-20 seconds. Every layer should be placed in a thin incremental layers, not more than 2 millimeters, and polymerization of every layer. Outer layer should be a little bit overbuilt, so the initial filling should be a little bit high, because oxygen inhibited layer is formed. This oxygen inhibited layer should be cut at the stages of final finishing and polishing, and thus giving restoration a shiny, strong surface. Sometimes it is recommended to cover outer surface of the restoration by resin adhesive system once again. Rebonding, such a term we have, rebonding. And this is a very, to some extent, it's good, because when there were polishing and cutting of excess of filling, possibly could be done some micro injuries to enamel. Micro cracks can occur, and when resin adhesive is reapplied again, all these micro cracks is covered. Thus, tooth is prevented from sensitivity in a consequence. Light curing of resin composites is initiated by light in the wavelengths ranging from 450-500 nanometers. This is blue light that can damage the eyes. So an orange filter should be used when the light is in use. And actually, both patient and both dentists should use protective orange glasses. Light curing units. Actually, modern dentistry presents 4 possible light curing units, but the most widespread between them is quartz tungsten halogen lamps and light emitting diode lamps, as well available argon lasers and plasma arc xenon lamps. But they are not so widespread, and basically I stop my attention on these 2, tungsten halogen and light emitting diodes. Benefits of light emitting diodes. They provide visible light in the broad spectrum, which is filtered to limit the wavelengths output to between 450 nanometers, and at the same time minimizing heat. Somehow they are very noisy because they have fan in this device to stop overheating. Light emitting lamps, they emit blue light over the narrow wavelengths band, which closely matches the absorption spectrum of the most commonly used photoinitiators. So they emit virtually no heat during use, which will reduce the thermal change that a tooth is subject to during curing. So this is the main characteristics of light curing lamps, and they are widespread nowadays in dentistry. Amalgam, another restorative material. So dental amalgam is a mixture of mercury and an alloy containing silver and tin with added copper and zinc. So dental amalgam continues to be used despite concerns about health and the environment because it has high clinical success, known performance, relatively low cost, and is easy to manipulate. Composition. Modern formulations of amalgam has a great amount of silver in their composition, almost in equal proportions tin and copper, a little amount of mercury, and some amount of zinc. Properties of amalgam. Dimensional changes. The setting reaction for amalgam involves a dimensional change. Strengths. The strength of dental amalgam is developed slowly. It may take up to 24 hours to reach a reasonably high value and continues to increase slightly for some time after that. Plastic deformation or creep. So amalgam undergoes a certain amount of plastic deformation or creep when subjected to dynamic intraoral stresses. Corrosion. Corrosion produces a restoration with poor appearance and may significantly affect mechanical properties. Copper-enriched amalgams contain little or no HAMA2 phase. The copper-tin phase, which replaces HAMA2 phase in these materials and is still the most corrosion-prone phase in the amalgam. So HAMA2 phase is not good one, and this is tried to be eliminated in the modern formulations of amalgam refillings. Thermal properties. Amalgam has a relatively high value of thermal conductivity. Thus, in constructing an amalgam restoration, a dentine is replaced by a good thermal insulator. That is, insulating lining should be placed. And biological properties. Due to mercury compounds, the usage of this material is doubtful because it can cause some harmful effects on the nervous system. On the stage of shaping, contouring, or removal of amalgam, there is a vaporization of mercury, and this is as well causing some harmful effect on the organism. And by the way, allergic reactions to mercury. Such allergic reactions usually manifested as a contact dermatitis or lichenoid reaction. Setting reaction. A HAMA2 phase is associated with increased corrosion and lower strength. That's why modern amalgams have low HAMA2 content due to the presence of higher amounts of copper. Actually, copper replaced mercury. The copper acts to convert HAMA2 phase to HAMA1 phase and the formation of a silver-copper alloy. Again, I should stress your attention that well-condensed amalgams are stronger than poorly condensed, as more of the weaker mercury-rich HAMA2 phase is removed during carving. So please remember this phrase. Cavity design. Actually, cavity design is similar to that of black. Should be straight walls, floor should be straight, similar box shape. Design is given, but necessary to keep in mind that amalgam don't has any adhesion to dentine. That's why the only one possible mechanism of interlocking is mechanical. That's why undercuts should be prepared inside the walls to keep the amalgam inside the caries cavity. At the same time, it is recommended to make inlet of the caries cavity a little bit narrower in comparison to the all sides of the caries cavity. Once again, because amalgam don't have any adhesion, it relies only on the mechanical retention. Technique of applying amalgam. First of all, trituration or mixing. Specialized triturator are used for mixing the amalgam, or previously the amalgam were mixed by hands, but right now this technique is out of use. Basically, triturators and specialized encapsulated materials are used. Condensation. Following trituration, the material is packed or condensed into the prepared cavity by ultrasonic vibration and mechanical condensing tools. Carving. During carving, the excess amount of mercury-rich layer is removed, and this is the well appropriately carved amalgam don't possess great amount of mercury. Keep in mind this idea. Polishing. Polishing is carried out in order to achieve a lustrous surface, having a most acceptable appearance and better corrosion resistance. The filling should not be polished until the material has achieved a certain level of mechanical strength. Otherwise, there is a danger of fracture, particularly at the margins. When it goes about any restorative materials, we should remember about dental bases and liners, because without them, restoration to some extent is impossible. And the task of liners and bases to prevent thermal stimulation to the pulp from restorative materials and provide some insulating property to the pulp tissue. So, objectives of pulp protection are as follows. First of all, therapeutic, it's to stimulate odontoblasts to lay down the reparative dentine and encourage remineralization of dentine. It can act against any remaining bacteria as well. Protect from temperature. Metal restorative materials such as amalgam and gold will transmit changes in temperature from the oral cavity, and in the absence of a suitable layer of dentine in deep cavities, additional protection must be provided. Protect from chemicals. This may come from oral cavity, bacteria, or from the restorative material. Seal the dentinal tubules. This will prevent fluids containing bacteria, molecules, and ions entering the dentinal tubules, and, as a result, prevent pain and possible further caries. All of that, what I have mentioned right now, deals with therapeutic lining. We call it in our health system, dentistry that we use in Ukraine, our classification, it is therapeutic lining. But still, these requirements can be used for any other dental liner as well. But This is typically for therapeutic lining. And now we move to base liners and their objectives. So the main function of insulating lining or cement base is to provide thermal and chemical protection for the pulp. For example, under amalgam or self-cure composites, amalgam will provide temperature and self-cure composites provide toxicity due to free monomers. That's why cement base is of critical importance when it goes about these restorations. Another function, to supplement mechanical support for the restoration by distributing local stresses from the restoration across the underlying dentine surface. In endodontics, base cement is used to separate root sealing and crown filling. Some endodontic sealers could provide adverse effect on crown restoration. For example, eugenol-based endodontic sealers can negatively influence resin composites, so they should be separated. Available materials for liners and base cements. So liners, it's therapeutic linings. We have calcium hydroxide material, it can be chemical and light activated, and zinc oxide eugenol. Base cements, for these linings, isolative linings, such materials are used. Zinc phosphate, glass ionomer, zinc oxide eugenol, flowable resin, and polycarboxylate cements. I will start from the calcium hydroxide lining. So calcium hydroxide lining has such properties. It has the greatest pH, very alkaline environment, more than 12 pH. That's why it creates a cytotoxic effect that stimulates pulp to produce reparative secondary dentine. It possesses bactericidal properties due to the great alkaline environment. With this material is easy to manipulate. It has a rapid hardening. The only one drawback, it is soluble if it is chemical cured. Soluble when it's subjected to the oral liquids. But if it is covered by cement lining, base lining, it is strong enough and not soluble. But we should understand that chemical cured composite release calcium hydroxide into tooth tissues. And if this process develop, material is resorbed. So sometime on a rare visit, when dentist removes cement base lining or temporary dressing from the tooth, he cannot find any calcium hydroxide material because it was resorbed. It's a sustained process. So when a calcium hydroxide releases its ions into dentine, hydroxyapatites of dentine, at the same time it resorbs. So it can't be placed under the final crown restorations. It's necessary to keep in mind this quality of calcium hydroxide material. Available formulations. It is suspended in a solvent. It is paste-based formulation. It's the most favorite one, and light activated as well, used one and good one. Properties of paste-based formulation: release more calcium in comparison with light curing, and light activated formulations, they are not soluble, but they are not so good at releasing calcium. Not soluble, it means that they can be placed under resin composites in a final crown restoration. Calcium hydroxide materials used with such techniques: indirect and direct pulp capping. Indirect pulp capping, it is placement of calcium hydroxide material in the places close when there is a proximity of pulp exposure, close to the pulp horns, but still the thin layer of dentine is preserved. Direct pulp capping, it is technique of laying calcium hydroxide material in above exposed pulp horns. These situations, it is accidental exposure of pulp chamber during probing in the case of deep carious lesions, and traumatic fractures of the tooth or iatrogenic exposures during cavity preparation. In this way, it will be pulp exposure in one point. Technique of placement of calcium hydroxide material. So here you have indirect and direct pulp capping. So indirect pulp capping. Material of calcium hydroxide can be placed in a thin layer to the whole bottom of the carious cavity, or it can be placed in the projections of pulp orms. Indirect pulp capping, directly to the exposed pulp orm. Materials for therapeutic linings. So the most favorite and the most widespread, it is Dicall, company Dense Ply, and Life, company Care. Both of them is chemically set materials, mixed base and catalyst. So in these two tubes we have base and catalyst. They are mixed together, and thus we have the ready-to-use material that is placed in the deepest aspects of the carious cavity or in the projections of exposed pulp orms. The main task of material, of calcium hydroxide material, to stimulate pulp to produce reparative secondary dentine, and thus protecting the tooth from being affected by microorganisms. Calcium hydroxide materials available in light curing formulations. Company Vocco Calcimol, company Vocco Calcicur. Just be aware that such exist, and you should know the few representatives. That's why I put in this lecture this information about representatives of any group of material. It's essential for the students to know at least few of them. Isolative lining, zinc phosphate cement. It is the most widespread isolative lining, base lining. Base lining is placed under amalgams, under chemical cute composite, and as a layer between root filling and crown filling. That is indications of base lining. Positive qualities of zinc phosphate cement for this case as a base, because it is used as well as a lutein cement, but we will discuss it as a base cement. So positive qualities: good heat insulating properties, low toxicity, and correspondence of the cement to the coefficient of thermal dilatation of a dental hard tissues. And disadvantages: soluble, soluble if it is subjected to oral liquids. But if it is covered by restoration, final restoration, it is strong enough. Mixing. Powder and liquid mixed together. At first some amount of powder added to the liquid, and then the rest amount of the powder mixed together to get appropriately formed restorative material. The peculiarity of mixing the zinc phosphate cement, it is that during mixing the heating occurs. That's why mixing should be done on a cold glass plate, because the cool will stop the heat, and thus mixing time can be prolonged a little bit. But necessary keep in mind that this material set very fast, so mixing should be not so long, but fast, quick, to put the material inside the carious cavity in appropriate stage. Base lining is placed to the pulpal wall, and somehow it should be extended to the walls, but not cross the enamel dentine junction. Because opposite, there would be light chemical cured composite will be compromised if cement is cross enamel dentine junction. Examples of base isolative linings: Spofa dental adhesor, calcer phosphate cement, GC company produces glasionomer cement light activated, Fuji lining. Temporary restorative materials and their placement. So temporary dressings is a dental filling which is not intended to last in the long term. They are interim materials which may have therapeutic properties. A common use of a temporary dressing occurs if root canal therapy is carried out over more than one appointment. In between each visit, the pulp canal system must be protected from contamination from the oral cavity, and a temporary filling is placed in the excess cavity. So, such indications we have for temporary dressings. First of all, to improve patients' comfort by preventing sensitivity, preventing food packaging, restoring appearance, and covering sharp margins of the cavity. Second, to provide a sedative effect on inflamed pulp. It can be used as an interim restoration before placing the final restoration, in endodontics in particular, as a planned procedure prior to placing a laboratory-made restoration, to assess the prognosis of the tooth or pulp, to prevent drifting, over-eruption, tilting, or gingival overgrowth, for caries prevention by using a fluoride leaching material such as a glasionomer. So these are indications for temporary dressings in dentistry. Available materials: zinc oxide eugenol, zinc sulfate, glasionomers, polycarboxylate cements. Zinc oxide eugenol cement. They were introduced in the dentistry in 1890s. So they are bactericidal, they are cheap and easy to remove. They provide sedative effect to the pulp tissue due to the oil clove. So actually, that is the main characteristic of them. But they are not indicated to use together with resin composites. So be aware of that. Eugenol provide adverse effect on a resin composite. Such representatives: calcinol and Z-temp. Zinc sulfate cement, biocompatible material, don't provide any toxic influence to the pulp tissue, biocompatible with any other materials. It is available in the powder, zinc sulfate, mixed together with the distillated water in a ratio 2:1. Mixing time 20 seconds, working time 50 seconds. Setting time up to 5 minutes. Here you have this dentine powder, zinc sulfate cement. Company JC, such material for temporary dressing is Caviton. Dentine powder is Vladmiva, Caviton JC company. Technique of placement. Taking into account that temporary restoration is of great favorite use in endodontic practice, so the root canal, the pulp chamber should be covered by a cotton, small ball of cotton, and then above it dentine paste is placed. The cotton is done in this way to prevent packaging of dentine paste to the root canals. Possibly it's interim restoration and the root canal is filled. So this material, the main task in the case of endodontic, to prevent packaging of food and to make the patient comfortable during eating. Excess of dentine paste is removed with a flat plastic instrument, or the excess can be removed when the patient is given the cotton roll and just asked to bite on this cotton roll. And at the same time, the material is appropriately condensed into the caries cavity and excess is removed. Patients should be given the recommendation not to eat for 20 minutes and not to drink anything, because the set-in time should be for this material. And be aware that this is temporary dressing, so it's not strong enough and can be cracked, and failure of this material is possible, of course. It's not strong. And finally, I want to end this lecture in such conclusion. So the initial need and genesis of restorative materials was, and still is, very simple. To provide protection to the pulp, eliminate postoperative sensitivity, maximize the tooth's ability to recover and maintain its function, thus providing appropriate aesthetic appearance of the tooth, and at the same time the restoration should be long-lasting. Recent advances in materials and increased understanding of their application and the perpetual evolution of dentistry stress the need for us to constantly evaluate how we perform as practitioners. Hence, the importance of continuing education and communication among colleagues. And from this conclusion, I want to give you such phrase by father of modern dentistry, Greenwald Deman Black. And he said, the professional has no right to be other than a continuous student. And think about this phrase in the view of constant long life professional education and development. During this lecture, I used such references. You can see Applied Dental Materials by John McCabe, Application of Nanocomposite Materials in Dentistry, Materials for Direct Restoration of Teeth, and Atlas of Glacionomer Cements. So thank you for attention and have a good day.
Thank you. Thank you, Professor. Thank you so much.
Thank you, you too. Have a nice day.
Thank you. Goodbye.
Goodbye.